Good morning, everyone, and thank you for joining us today. We are delighted to welcome 4 speakers, panelists. Firstly, Dr. Anita Donley, OBE consultant physician, previous chair, Mid and South Essex ICS and vice president of the RCP. Caira, partner at Wright Arkitekter. Kieron Boyle, CEO Guys and St. Thomas's Foundation. And finally, Wright, architect practice leader here at Arup. Before I begin, I'd like to share a couple of housekeeping points, which hopefully you can see on your screen. In the first half of today's session, we will hear from our panelists, and the second half, we're looking forward to a lively Q&A and discussion. You can bring up the chat panel by clicking the small chat box right hand of your screen. Please add your questions during the first half. They will go to our admin team behind the scenes. Here you can post them in the second half of today's session. We'll aim to get around to as many as possible before our time is up to date. I should also mention that we will be filming today's event for those unable to join us, and of course, following today's webinar, we will issue a video link transcript. But before we hear from our speakers, a few words from me. Delivering affordable healthcare is a huge challenge, a challenge that is evolving. When one thinks about healthcare, we need to consider the broader context. We need to think of the wider ecosystem. For me, there are many opposing forces at play that include but are not limited to consumers' increasing involvement in healthcare decision-making, the rapid adoption of virtual health and other digital innovations, the push for interoperable data and data analytics use, so-called big data, and more recently, unprecedented public-private collaboration in vaccine development. The future of healthcare ecosystems developed by our Foresight and Innovation team is a global collaboration by all of our regional healthcare leaders and was produced over the best part of a year that in part spanned the beginning of the COVID-19 pandemic. There are a number of definitions of an ecosystem. The one I think that best encapsulates what we mean when we think about healthcare ecosystems is the complex of living organisms, their physical and all their interrelationships in a particular unit of species. I think for someone who has been in the business of maintaining and design healthcare buildings for well over 30 years now, I feel that we are probably in the right business at the right time. This wasn't always so, and we have to admit to ourselves and to each other that years of austerity have led to an obvious decline in the healthcare estate. But I'm seeing real signs that healthcare will be better funded over the next few years. And because of the pandemic, we have all reconnected with our healthcare service, a healthcare service that will hopefully continue to deliver best-in-class healthcare interventions. We probably all know that the UK government HIP programme that comprises confirmed funding for 40 hospitals. This is hugely challenging, and the programme suggests that we will need to speed up construction, think more strategically about repeatability, and look to develop robust modern methods of construction. Aligned with this, we should also mention the NHS's ambition to achieve net zero carbon. All of this, of course, needs to be reviewed in the context of the UK government's drive to build back better. With this significant once-in-a-generation build programme comes great responsibility. For me, this is a recognition that to properly succeed, planning alone is insufficient. One must improvise as well. We can't possibly have all the answers at the start of a project, and as a consequence, we must be brave. Along with improvising, we must also try to imagine what the future healthcare delivery will be. We must not deliver healthcare buildings of the future that are not adaptable for the revolution that will surely come. And here I'm referring to the digital revolution and, of course, the revolution that suggests that more care will be delivered outside the traditional healthcare environment. When budgets are being developed for the hospitals of the future, we need to ensure that the cost plan truly reflects the aspirations. We must not deliver hospitals in the third decade of the 21st century that are no better than the ones we delivered in the early noughties. Today, we will focus in on 4 key trends shaping these decisions: the long-term implications of COVID, what have we learned, the digitalisation of healthcare services, and how good design is able to improve health, and finally, healthy ageing. I'd like to hand over to our first speaker now. Anita, the floor is all yours.
Thank you very much indeed, Dave. Thank you very much indeed, and good morning, everybody. So as the jobbing physician on the presentation, my role, I think, will be to just go through in a clinical way a thematic analysis of the current context within which we find ourselves on the front line of medicine. Fundamentally, this is a really good example of a paradigm shift. Everything has changed in the last year in terms of where we do things, how we do them, who indeed does them, and with what we undertake this job. One of the very important aspects to consider when thinking about a health ecosystem is clearly the societal context, the interaction between humans and technology, not least perhaps public trust and public confidence, which are often right at the bottom of the list, but acknowledged and not addressed. I think Isaac Asimov actually summed this up very, very well. This is a situation where we have a clear and present danger and a clear and present opportunity. And may I have the first slide, please, Catherine? So here we see what Asimov described as a Seldon crisis, a seemingly catastrophic social and political situation that, to be surmounted, would eventually leave only one possible and inevitable course of action. Now, this involves both an irresistible external pressure and an irresistible internal pressure. And we can muse perhaps in the webinar what those two aspects of sectoral pressure might be. But I do think we are at this stage, and it does present us with a set of opportunities, but as I've said, also a set of clear dangers. So next, please, Catherine. So here is a reflection from an IBM software engineer called Frederick Brooks in 1975, talking about effectively acting and changing a context in which technology supports clinical care delivery. And he said, well, you know, it all starts off with some techie nerds in a back room developing something which is really cool in terms of a technological solution, a digital solution. But as they need to adapt this to the context within which it is provided, it goes through a series of stages. And I want you just to look at the penultimate block here, the human reaction which accompanied this progression. He studied this over a number of years. Initially, people were really excited about the opportunities, then they came to depend upon them, and then they became disempowered. The very thing we want to avoid, and in fact deliver quite the opposite, had happened. And he termed this the tar pit. It gets very, very sticky as you go through these stages of the process. Next, please. Thank you. So if we consider perhaps a group who are at the most risk at the moment, those who suffer health inequalities in our population, the lower income, jobless, people who are in social housing, who have a physical or indeed mental disability, who have a relatively low education status, who are sited in a rural location, who are perhaps homeless, and whose first language is not English. We can add to those who are most likely to suffer the disasters of health inequalities and all that's associated with that in terms of comorbidity. We can add older people. And we have double jeopardy here because digital exclusion particularly affects these groups. Older people, especially in the top right block, a fifth of households with someone over 65 years have no internet access, and half of those over 75 lack digital skills. That's last year's ONS report on digital access. So one of the things we're going to need to consider very carefully is how the ecosystem adapts to mitigate these inequalities. We don't want to bake in further exacerbation of inequalities that already exist. And we have the opportunity to do that, but it won't last long. Next, please. So here is an interesting article in the Wall Street Journal. I put the reference in there, and it deals with early experiences with regard to the use of technology and particularly remote consultation in the context of the early months of COVID. And it's one of the earliest pieces of evidence that's coming out. Clearly, over the next 18 months, 2 years, we will accrue a large number of publications relating to this. But this is a very, very early one from the first 3 to 4 months of the pandemic. Next slide, please. So here we see something happening, and it's not simply the patient will see you now, that phrase which sums up the kind of shift of the balance of power between the doctor and the patient, but it also sums up how people were using the opportunity of virtual visits in the first 3 months of the pandemic. And you'll see from that, a very clear shift from 0.8% of outpatient visits to 30% of outpatient visits within that very, very short period of time. Now, clearly there are questions about sustainability there. Next, please. And here we see, and I'm sorry this slide is a bit complex, but if you look at the top bar chart, you will see that surveyed doctors indicated that they continued to intended to continue offering remote consultation in this way for several very important, very common and very demand-heavy aspects of medical care and medical management. In the lower bar chart, you will see what they regarded as being barriers to the continued use of virtual care. Now, this is a US data set, so the reimbursement bar here, I think we need to consider in the context of NHS procurement and a general overall commissioning context. Next, please. And here we hear from the other side of the coin, which is what would people choose, patients choose, and for some perhaps not as expected common diseases, there was a significant indication that people really liked this and wanted to carry on using it. That succeeds my slides from the Wall Street Journal. Next slide, please. And so here, looking to older people, we need to turn our abilities and our concentration to considering population health, the opportunity to add health and well-being to years of life, to consider the health ecosystem as it's supported by a major political move and a policy imperative around integrating health and social care in the local context, in connected communities, that aspect that Dave was referring to earlier as care closer to home. Hospitals are no longer buildings with walls. They are an entirely different construct, as indeed is the role of the modern specialist in healthcare. Understanding the data analytics and having the capacity and capability to leverage that to influence healthcare more generally at a population level is one of these major opportunities. And key areas where this will have a major impact are around long-term conditions and multi-morbidity. Next, please. And so if we turn to the modalities, really, perhaps around data and digital, there are some themes here around what we need to pay attention to. One is, what are the new capabilities and competencies that we'll need to identify and develop and indeed educate both the population and the workforce in? There are going to be two aspects to the workforce. I think there's going to be, the experts in data analytics and the digital workforce, and then there's going to be the concept of digitally enabling the workforce that we have at the moment and the workforce of the future. And both of those have major implications for educational programs, as well as the implementability and the adoptability of modern solutions within the organisational construct. I've mentioned population health, prevention, precision and anticipatory care, all going to be major features of healthcare delivery in the next century. But there's one aspect which hasn't really been considered at all yet, and that is the effect on clinical practice. Those of you who read the Health Service Journal, and in fact the local newspaper, the national newspapers, will have seen that the human reaction exhibited in primary care, where some surgeries are now withdrawing the digital accessibility because of pressure of work. We see specialists in hospitals, particularly in diagnostics, receiving referrals for patients to have investigations who have never been seen physically by a GP or anyone else in primary care. And that has an impact on demand and capacity, both in primary care and in secondary care. Next slide, please. And so here are the key modalities that are real and present in the next sort of 20 years or so from a clinical perspective. So that aspect of really making the population data work for us, Understanding that in local authorities a huge amount of information is held around the population profile. The Joint Strategic Needs Assessment is a data set which is held by local authorities and shared with clinical commissioning groups and informs priorities in terms of commissioning, prevention, screening, etc. There's the aspect of system level demand, system level networking capacity and capability in response to that, which is a much more nimble way of dealing at a macro level with a population with fluctuating demand and flow. Corporate level functions such as real-time dashboards and dynamic flows, safety and quality metrics, indeed also heads up clinical decision support, the implications of remote practice, consultation, surveillance, virtual wards, and these are advancing at a massive degree of sophistication very, very quickly worldwide. We've seen evidence from Australia and also from one of the least digitally mature trusts in England, in West Herts, with regard to the use of virtual wards. And then, of course, there's the learning aspect, the artificial intelligence, which will make all this technology adaptable, and the robotics. Next slide, please. And my last slide here. So here is Atul Gawande reflecting on why doctors hate their computers. And this is well worth reading for a sort of reality check about the clinical context. But he says medicine's a complex adaptive system made up of many interconnected and multi-layered parts, which is meant to evolve with time and changing conditions. But software is not. It's complex, but it does not adapt. And that's the heart of the problem for its users, us humans. And I leave you with that thought about the societal context. Presentation ends. Thank you, Dave.
Thank you. Thank you very much, Anita, for that. For me, there's a number of take-homes. I was absolutely surprised to hear that 20% of households have no internet access. I don't think I'm that surprised to know that perhaps 75% of over 75s lack those digital skills. One of the things I think is going to hold as a question perhaps for later is maybe some of the ethical issues around the implementation of these modern systems, and I'd be interested to hear what that might look like. Thank you. Our next speaker, thank you very much, Cristiana.
Yes, thank you very much. I would like to ask Catherine to show my presentation if possible. Or should I do it? I might maybe start myself. I hope you see my presentation. Yes, thank you very much. Thank you, Dave, for introducing me. I'm very pleased to be here today. My name is Cristiana Caira. I'm a partner and board member at Wright Arkitekter based in Sweden. I'm also professor in healthcare design at Chalmers University of Technology. Today I'm going to give you my perspective, which is a typical architect's perspective on the question of future healthcare ecosystems. I would like to start with this definition because it comes actually from 1948, which is a very long time ago, but it is as modern as it can be actually. Health is not absence of disease or sickness. Health means to achieve an optimal balance between physical, mental and social well-being. When I have my students at the master course of healthcare design, I usually tell them that it's they might probably not work with hospital planning in the future, but they might work with health as a component of their everyday life as architects planning cities or schools or housing. Health is a component of our work of architects and planners in a much broader and holistic perspective. We are at a tipping point in a shift from a hospital-centric healthcare system into a networked healthcare. And in Arup's report, it is very clearly described why we are there today. We have a pressure from an aging population, chronic diseases, raising individual demands, economic and staffing challenges, as well as the potential of telemedicine, e-health, artificial intelligence, portable devices, and the development of technology that will enable healthcare to move out from hospitals into homes, healthcare centers, community centers, specialized clinics, etc. In Sweden, we are just in the middle of this transformation, and we don't really know exactly what this will mean for us, architects and planners. We are just in this position at the moment. We are planning projects that take between 5 and 10 years to be planned and delivered. And at the same time, healthcare is changing so rapidly that many of these buildings might be obsolete already when they are just completed. How do we deal with the fact that healthcare services are changing while it takes so long time for buildings to be planned and completed? I'm going to give you some case studies coming directly from our work at Wright, and that showcase some of the current trends, but also future scenarios of healthcare ecosystems. Health promotion first. I think that's very clear in Arup's report. Working with health means starting from health promotion and not from curing or taking care of sick people, the real end of the chain. A design approach where the public and shared spaces are weighted with equal importance as the private and commercial spaces. This project is a project from Stuttgart, where homes of different sizes, price ranges, and prepared for all phases in life are blended with an active street level to activate citizens both during the day and in the evening. Public buildings is a unique opportunity in our cities to add public outdoor spaces and support sustainable mobility, as we see in this project. By Bogotá's largest favela, missing all basic public infrastructure, the hospital becomes a healthy city addition that might transform this neighborhood completely. Having access to quality outdoor space within the urban context has shown to be crucial during the pandemic for both our mental and physical health. We will see more of these spaces, like this roof terrace in a housing project in Gothenburg, Sweden. Urban spaces like Hamntorget in Stockholm, where a piece of urban design, a long table, is the feature that activates the square and fosters interaction. All the hospitals will soon be remodeled for other users, such as Bromma Hospital in Stockholm, being transformed at the moment from a closed mental health clinic into an open and welcoming healthcare center specialized on care for the aging population. In this project, we are also taking chance in reusing many of the building components and materials to make these a very important example of circular economy and architecture. Care will be moving out from hospitals into homes, as well as provided in pop-up mobile units, such as these designed during the pandemic for COVID testing. Health will come closer to the users, located by a square, a station, a parking lot. Smaller mixed-use community health centers will give the right care at the right place. In this case, a healthcare center mixed with housing for elderly, sharing a central commercial public space next to the train station, close to the city center. Another trend, we will see a destigmatization and normalization of mental health, and body and soul coming together, being taken care of at the same time, maybe in the same buildings. This is also a new trend that will change our building structures in the future. Hospitals will still be there. Of course, we will have hospitals, but they will be more high-tech, specialized, digitally connected and integrated with research and med tech, flexible and adaptable to enable the rapid development of technology in treatment and diagnostic. The COVID pandemic has shown that the importance of flexible, adaptable and general buildings, as well as the importance of healing environments components for both the well-being of patients and staff. And to conclude my short presentation, we might not know today how the hospital of the future will function or look like, but after this pandemic, we might all agree that a human-centric design approach will always be a crucial element of the healthcare spaces of the future that are built for humans and that are workplaces for humans as well. I thank you very much for your attention, and I will be pleased to answer your questions later during the webinar. Thank you very much.
Thank you very much, Cristiana, and thank you very much for a thought-provoking presentation. I think what's interesting is that whilst healthcare delivery systems may be nuanced across the globe, it seems quite obvious to me that the actual characteristics of a healthcare ecosystem are probably the same and similar wherever you are. It'd be interesting how we pick that up in the Q&A session. Our next speaker is Joe Wright from Arup Arkitekter.
Sorry, Joe, you're on mute.
Good morning. Sorry, technical glitches. Hopefully that's working now. It's great to be here. This is a subject, design of buildings that promote well-being is a subject that's really close to my heart. And it's been a delight over the last 2 or 3 years to work on Pentra Owl, which is an extraordinary innovative project in West Wales. And Dave should take credit for, I think, being the initiator of the idea of spotting the potential of a very unloved post-industrial site as somewhere that could really become a catalyst for promoting well-being in a community which scores, unfortunately, very high on the Welsh Government's index of multiple deprivations. It's an area that where people suffer from a number of chronic health issues, where educational attainment is low, and where there is a lack of quality jobs. And this project has come together, and we very much hope will be starting on site this year to address a lot of those challenges and to really regenerate a site in a way that leaves it in a richer ecological state than we find it. So the project has been inspired by the Welsh Government's Wellbeing of Future Generations Act, which is a really inspiring piece of legislation from which I think the rest of the UK could learn. It's very much about collaboration across agencies, and its scope extends far beyond just physical healthcare assets. It's all about inclusivity, it's about promoting healthier lifestyle choices. It's very much about preventative care and addressing challenges before they turn into those chronic problems. And of course, it's about delivering economic and social value and about social cohesion and strengthening community. So the site sits next to, this is a view from the north across the Nidafn River, which sits just off the Lager estuary. It's an extraordinarily beautiful site, although at the moment in a state of some degradation, having fallen out of use in the middle of the last century. When we first started working with the client group, which comprises Carmarthenshire Council, the Hildar Health Board, and various universities who are key stakeholders, we they had a schedule of areas, they had a schedule of accommodation, but we wanted to get under the skin of what did they really want to deliver. And these were the values, the vision and objectives that came out of those discussions. It's about creating a sort of permeable, connected environment. It's about something that is very much co-created. It needs to be accessible and empowering. One of the early phrases that came out was, this is about empowering wellness rather than addressing illness. It needs to be holistically sustainable. Flexibility and adaptability, as Cristiana was saying, it's so important that we're not building things that are obsolete before they ever come into service. And so there's a huge element of adaptability in what we've put forward. And fundamentally, it's about providing whole life value, both in the operational costs and impacts of the building itself, but also in delivering value to that local community. When we came to the project as architects, which was sometime after Dave had come up with the idea and a master plan had begun to coalesce, there was an idea about creating two separate buildings. It was to be a campus for health and well-being, but there would be a health building and a wellness building. Wellness essentially being a replacement for the obsolete leisure centre in Llanelli. I think there'd been an idea about linking the buildings with a big canopy, but we came up with the suggestion that actually we could completely integrate the facilities within the building to bring together cohorts who might not cross paths otherwise, with a view to broadening horizons, creating new potentiality on the back of this development. So this is the master plan as we evolved it, and we've only developed the phase 1 building to date. The wider master plan comprises a range of senior living accommodation, from supported housing to full-on nursing care, together with buildings for business incubation for life sciences businesses. And the phase 1 building it's a beast of a building in the context of Llanelli, which is a very kind of small scale space. This is a place. This is a 25,000 square metre building, and it's articulated to nestle into the landscape to mitigate the impact. We don't want it to feel foreboding or off-putting. It's also incredibly important that it's accessible from every direction. We don't want anyone to feel disadvantaged if they're coming in across the lake from the town centre on foot rather than coming by car from the south. It needs to feel inclusive and welcoming from every approach. Early on in the design process, we defined some key design drivers, and the first of these was light. Daylight is obviously absolutely essential to well-being. It creates delight in buildings. It's also phenomenal in its potential to create renewable energy. So all of those thoughts influenced the way the building developed. Landscape is another fantastic potential of this site. As I said, it sits alongside the Lauga estuary, and there are breathtakingly beautiful views across the estuary. The site is at the moment not in a particularly rich ecological state, so there's an opportunity to enhance that landscape, to create a publicly accessible landscape that encourages people to get out, not least hopefully the people living in the zones labelled 4 on this diagram, the older people living on the site, but to encourage people to get out and be active and take advantage of that wonderful setting, as well as, of course, creating great views out from the buildings and amenity spaces around the building. And finally, Llanelli. We want the building to feel like it belongs in this place. It's not an alien imposition. It's not something that's kind of fallen out of the sky. It draws on Llanelli's heritage of historic buildings, of scale and grain, and the kind of texture of the place. So essentially what we've got is quite a complex building. The leisure facilities drive a need for big footprint spaces, but actually all the other accommodation, which is a combination of clinical delivery outlined in blue. Essentially that's a kind of almost a hospital outpatients type provision. Business development, business incubation outlined in pink, and education, and that is higher education, not for doctors, but for other allied healthcare professions. All of that is designed as very simple, 15-metre deep space, great for daylight and natural ventilation, fundamentally adaptable and constructible using very simple systems. So this ought to be a good, robust, long-term solution. And I've got just a series of views of the building. This is a view of the sort of central approach from the south down the covered street, which forms the community heart of the building. Views in either side into business incubation, hopefully something reasonably sort of high-tech and interesting, potentially the 3D printing of medical devices. And on the left-hand side, views into a research laboratory. So really bringing those extraordinary, sophisticated uses right to the forefront of the building as people come in. The sports facilities obviously take a very different approach. Both the wet and dry sports look out to the north, so we can have unencumbered daylight, but looking out over the lake. So wet and dry sports. The healthcare facilities are designed to be, calm, well connected to landscape. Very simple, straightforward spaces, but of a high quality that makes the users feel valued. And the education spaces, again, benefiting from views both to the internal street and out across the estuary. And I guess this is how we see that central space that brings those uses together. People coming for appointments in the healthcare facilities who may well be directed across to the gym to work with a trainer to address their problems directly. The opportunity to stop and have a cup of coffee, to connect with other members of the community, to rub shoulders with people in the education and business incubation parts of the buildings. So it's a really holistic approach to trying to address the challenges that Llanelli faces. I think in some ways it's very interesting listening to Anita and Cristiana. This is drawing on a lot of the themes that they mentioned, and I think it's a great opportunity. I think for me it's an exemplar of how healthcare should be provided going forward as part of a much richer ecosystem, and hopefully an example of regenerative development that will, as I said, leave the site in a better state than we found it. Thank you.
Thank you very much, Jo, for that. Interesting. I wonder if the project wouldn't have been possible without the Future Generations Act, and perhaps we could pick that up in our Q&A. Also, I really like that idea of empowering wellness as opposed to just treating illness. So I think that's absolutely on point. Our final speaker is Kieron Boyle. Kieron.
Thanks, Dave. Can you hear me?
Yeah.
Great. So firstly, I'm not Siri nor Alexa. Just having a few technical difficulties joining today. So my name's Kieron. I run a foundation called Guy's and St Thomas's Foundation. Part of us is an organisation called Impact on Urban Health. We're dedicated to unlocking the potential of cities to be healthier, and we do that by seeking to understand the deep causes of urban health issues and explore different ways of addressing them through combining the best sources of data, evidence, lived experience, and practical interventions. And it's a pleasure to come after such inspiring presentations. I'd like to, if I may, start with 3 provocations. Firstly, are we here talking about healthcare ecosystems or actually just health? Secondly, if it is that, health for whom? And thirdly, following all of that, do we have sufficient players on the team? So one of the consistent things I think we've heard so far is that health is created in those places that we live and work and grow up. As the line goes, health is made at home and hospitals are for repairs. And to pick up on the theme of COVID, I think the story of COVID tells that all too well. Those most seriously affected by the virus can be found in hospitals, in intensive care units, which have done truly heroic work over the past years. But where do you find the people who are most at risk of the Well, that's in polluted areas and neighbourhoods with few affordable healthy eating options. It's in places with crowded transportation, poor quality housing, places where people have little say over their working conditions. And so that all matters. The positive of COVID, if there is any, is that perhaps we all understand that now a little bit more clearly. But I would argue that what the pandemic has actually done is just fast forward a clock on the health patterns that were there all along. They were less visible perhaps, but with just as great a human and economic cost. So what does that practically mean for healthcare ecosystems? Kat, I wonder if we might move to the next slide. Thank you. Well, what that means is that we need to design for health in its broadest possible sense. And as the excellent Arup report shows, we need to design well beyond the hospital. We need to think about things like affordable housing and healthier food environments, and opportunities for local economic regeneration. As work that we've done as an organisation with UCL's Bartlett School shows, we also need to design for how the health of individuals relates to the health of communities and the health of the planet. But that all brings us to the question of health for whom, the second area I want to touch upon. And that must make us look at issues of income and race. In this country, like most, being poor is bad for your health. In fact, we've seen an extraordinary stalling in healthy life expectancy over the past 10 years. There's now a near 20-year gap between those on the highest incomes and those on the lowest. But it goes deeper than that. Take, for example, black babies in the UK have over twice the risk of being stillborn. Black mothers have 4 times the risk of death in childbirth. Where we work in South London, nearly 1 in 3 black adults already lives with more than one long-term health condition. No other ethnicity is so disproportionately affected. Which begs the obvious question, which is when we're designing healthcare ecosystems, whose voices are we seeking out? What is the background of the professionals engaged? Where is the key performance indicator around equity? And if that all sounds a bit abstract, here are some practical examples. So as we touched upon, digital health holds huge promise for how we design healthcare institutions. Why travel to a hospital GP when they can come to you in your living room? But what if you don't have broadband? Or what if you're sharing a device amongst a family? Likewise, locating healthcare facilities within communities doesn't automatically make them part of the community. And it's interesting how much lifestyle medicine requires a certain lifestyle, especially time, often for people who need to work 2 or 3 often insecure jobs. So none of this is insurmountable, but I think these issues do need careful consideration. Which brings us to the final theme. So do we have enough players on the team? And I would hope that if people take anything away from what each of us has been saying today, it's that health is a collective. Shaping places, shaping our cities to improve health requires a collective effort, which goes much wider than the healthcare system and clinical interventions and indeed public health authorities. Absolutely includes urban planners, but also civic institutions, investors, big employers, and crucially residents themselves. And as we've heard with kind of the ideas around anchor organisations, that collective approach can start with hospitals themselves, not just in the hardware of what's built, but also the software of how it's run, from who hospitals employ and how they employ them to who hospitals and health systems procure from. So I'll draw to a close there. Healthcare is clearly on the cusp of a transformational shift in individual personalised and predictive medicine, and that's so exciting and will bring amazing benefits. But just as important is a transformation needed, and we've been discussing today, in thinking about ecosystems and the collective, in thinking about equity and access. As they say, when you shift an I to a we, illness becomes wellness. Thanks, Dave. I'll stop there.
Thank you very much, Kieron. I think your presentation reminds us that we do need to develop a holistic solution to consider the broader aspects of an ecosystem. Interestingly, you speak about affordability and housing, but he also reminded us that, you know, how do we separate? We can't separate wellness from issues associated with inequality. So there's some real broad concepts in what you've said. Thank you very much to all the presenters. Thank you very much for all those thought-provoking presentations. We move now seamlessly, hopefully, into the live event Q&A. There are some questions already populated. Please, can you keep them coming? If it's okay with everybody, I'll read out and I'll assign the questions to the panel, and please feel free if others feel that they can contribute. Anita, there's definitely a number in the Q&A for you. I'd like to just maybe ask you this one. How does a patient being referred without a physical GP consultation impact demand? Are you suggesting that they would not have been referred if they had been seen physically?
So I think that there are two answers to that. I am suggesting that some might not have been referred if they had been examined physically, because doing a physical examination is an absolutely essential part of that interaction between doctor and patient, but it does reveal findings on examination which guide you as to what are the most appropriate investigations. But in other circumstances, it will actually result in somebody being referred much more quickly and more appropriately. So I think that has an impact in terms of particularly diagnostics, as I said, imaging, endoscopy, those sorts of investigations, but also in terms of the immediate and timely accessibility of treatment. And so it lends a different light and shade to the behaviour that goes on collaboratively between that triumvirate of the patient, primary care and secondary care. And I think it is one to watch. Similarly, you know, when specialists in secondary care are hopefully playing much more on the field of integrated care with a care pathway that spans both secondary and primary care, there will be behaviours and input in there from the specialists which will impact on primary care and indeed on social care services. So I hope that helps to answer that one. I think it's probably a couple of others, Dave. I don't know whether.
Yeah, thank you. Yeah, thank you very much. Yeah, I've got the list in front of me, and I'm just randomly picking the ones that and distributing them. One question here, which is kind of interesting, is just wondering how we can future-proof hospital buildings as they are facing new concepts of hospitals different from old ones, and how do we ensure about addressing future requirements? I think Cristiana, I would very much appreciate your views on that. I think that's a question for all of us in the healthcare business.
It is a very important question for all of us, and for architects as well as planners and engineers. It is a very difficult question because planning hospitals that can be fully adaptable and fully flexible to the most advanced high-tech spaces and functions is very complicated and also very expensive. We have a very great example, a school example of that at New Karolinska Hospital in Stockholm, which is the really fully adaptable and super flexible general hospital structure of the latest projects that have been built. There is a difficulty in this, and in the latest projects I have been observing that when we usually ask clinicians what do we have to plan for when we think of the future, usually the answer we get is we might see an increasing of high-tech spaces, but the middle-tech spaces or low-tech spaces might decrease in hospitals and move out into community healthcare centers and other type of structures that are not so complex and high equipped. So the trend at the moment is to plan for very high level of flexibility and adaptability for high-tech spaces, and to think very smart and very sustainable for the rest of the areas of hospitals that might be in the future be rebuilt or used for housing, senior living, private healthcare providers, so that that we can reuse buildings in the future in a smarter way and remodel them. So my answer is yes, we need to think of adaptability and flexibility, but we need to think what areas, what units need to be growing in the future, and the ones that might move out from traditional hospitals we might be planned in separate areas that can be remodeled. We have an issue of financing projects, and we have also an issue of the climate issue. We need to build buildings that have a low climate impact at the same time. So we need to think very smart when we think flexibility and adaptability.
Thank you. Yeah, thank you very much, Cristiana. And just to echo that, I think from my perspective, we're seeing very similar challenges, I think, in the UK. Next question, Joe. It's inevitable that someone's mentioned the Future Generations Act, and it is a fine objective. We're seeing a lot of drivers to deliver projects within the ESOS are the same. But how do we ensure that the future projects are delivered within the Welsh Government's aspirations in order that they are? And I'd like to kind of broaden that out, because I think the other home nations, in my view, should have a similar piece of legislation to the Future Generations Act.
Absolutely. As I said, I think it's a really visionary piece of it's a really visionary piece of legislation, and I guess it's implicit in the current government's levelling up agenda. But how do we ensure that we are measuring outcomes? It's a tough question, and I suspect that it's we obviously have systems of doing post-occupancy evaluation of buildings and how they perform. How do we measure outcomes over time with significant populations, and the kind of provisions that we're putting in place at Pentra will take a generation to be proved. So I guess we have to trust our instincts as designers. We have to make decisions based on the best data available, and we have to we need political will to do things which are not always not always deemed to be best value, i.e. lowest cost. Too often those two are conflated. But to take a longer term view, it's a big challenge. Like, I have a very clear memory of one of the engagement sessions that we had with stakeholders on the Pentra project. One of the medics said, "The people I'm seeing today, this is too late for them. This is about the next generation." But we shouldn't do it. We shouldn't not do these things today, because the benefits will take some time to come through. It's absolutely imperative that we get to grips with the challenges, which I guess there was obviously an upswing in health with the advent of the National Health Service. But we're a long way on from that, and how do we get the same impetus to deliver better outcomes? I hope that the Welsh Government sticks to its guns. I hope that they really force compliance, and I hope the rest of the UK learns.
Thank you. Yeah, thank you very much for that, Joe. Kieron, question for you. How do you, and you kind of touched on this in your presentation, but how do you actually assist people with their behaviours in becoming more healthy in the first place, hence in reducing the need for long-term medical intervention?
Okay, it's a great question. So you focus on the environments in which people are. I think that's where the huge gains are to be made, and you focus on the very different ways in which people experience the same environment. So, very practical example: walking to a supermarket is where 80% of us spend most of our money on food across income levels. So, if you look, food that is affordable and healthy really varies. You've got a lot of money in your pocket. You can buy quite a lot of healthy food. If you have a lower income, the options available to you that are healthy and tasty are much reduced. So it's that way of framing the world, thinking about the environments in which we pass through. Very practical ways in which hospitals can play in that part too. Although, as you heard me say, I think we need to have a much broader frame of who's responsible for moving to that vision, which goes well beyond the NHS. But I think hospitals, we've been doing a lot of work with Guy's and St Thomas's NHS Foundation Trust, who are a great institution, about the quality of the air around hospitals. So in a lot of cases, hospitals, big cities especially, are like the last inner city factories. The quality of air around them is often very, very poor when you think about the number of deliveries going to a hospital, the number of people travelling to them. And what's more, that you have not just really poor air quality, but those people who are most vulnerable to the poor effects of air going to hospitals. The very practical things that places like Guy's and St Thomas's has done, and others as well, is how do you rationalise deliveries? How do you improve the air quality around the environment?
Yes. Yeah. Thank you very much for that, Kieron. Look, apologies to everyone. We are nearly hitting the hour. We are fast running out of time. I would just like to say, and apologies, there's been quite a lot of questions in the chat, not all of which we've obviously been able to address. One of the questions, or the themes of one of the questions, is kind of interesting, and I'll just leave this with you. One of the questions actually talks about us reinventing the wheel. There's an awful lot of things that we are doing now, and I saw Nucleus Hospital actually mentioned in the question. There's an awful lot of things that we're doing now that we were probably doing in the 70s, and I personally believe that we actually should spend a period of reflection as well, because an awful lot of things that have been successful in the past, we seem to have forgotten them. So with that thought, I'd like to thank again the speakers for their valuable contributions. I'd also like to thank Kat and Annabelle for all the work they've done in setting this up. So look, thank you very much for attending. And as I said at the beginning, there will be a video transcript issued to all attendees and those that couldn't make it, and that will be out in the next couple of weeks or so. Thank you very much again.